Good evening to all of the panelists as well as CCI, all the office bearers and all the persons who have joined in our webinar. And I will request many other people to also join the webinar. Today we will be speaking on a very interesting topic. I have attended many webinars as a delegate, as also as a panelist, and also we had a lot of talk nowadays going through all the CMEs as well as the big conferences, but this kind of topic is very unique. So thanks again to CCI for selecting such an unusual topic for today's presentation. So today we will be talking or discussing on Hilum, the first footprint pointing beyond the lung. So whenever we used to see a patient, the first investigation, being a pulmonologist, we used to write is the chest X-ray. And in the chest X-ray, the first thing, apart from the cardiac shadow, which will strike immediately our brain or our eye, is the hilum. So what is there in the hilum? Should we require any additional investigation? How to interpret the chest X-ray from a normal pulmonologist, from an oncologist, from a radiologist who doesn't have the adequate history and many of the times. So now I like to introduce today all of our panelists one by one. So today we have Dr. Nikhil Gupta from Ludhiana, who is joining here. He's a well-known radiologist. No introduction is required for him. We have Dr. Shweta Saraf, who is joining from Ahmedabad. Dr. Shweta?
Hello.
Yes. Hello. Then we have senior pulmonologist Dr. Tridib Chatterjee with us. Are you with us? Yes. Then we have Dr. Sudhindra Rangu. Sir, are you with us, sir? Yes. And also we have Dr. Satish Sharma, who is joining from Ranchi.
Not there, I think.
Dr. Satish Sharma.
Dr. Debraj, as of now, he is not there.
He will join later on. So, sir, we will not waste any time. So, we will have a brief discussion or brief presentation on what is there in the hilum, how to interpret an hilar shadow. And in the coming 10 minutes of talk, I will show certain cases where it is basically the history which will dictate the radiological presentation, and we cannot go by just what is there in the hilum. Is every unequal hilum to be followed by a CT scan, and in every CT scan whether hilar shadow to be followed by any investigation. So now I will proceed for my talk. Good evening to all the listeners, and thanks to all of you for attending the webinar in such a large number. So I am presenting a brief overview of how you will approach an unequal hilum. So what will constitute the hilum? First of all, we want to be assured of the fact that whatever we see in the hilum, it is actually constituted by pulmonary artery and by the pulmonary vein, both of them. So in a normal chest X-ray, this is how the left and the right hilum looks like, and the left hilum is situated in majority of the individual at a higher point above the right hilum. The pulmonary arteries, the light gray ones, will make up the most of the hilar density, whereas the superior pulmonary veins, dark gray one, they will make a relatively lesser contribution. So in general, it is by the pulmonary artery, and to a small extent, it is by the superior pulmonary vein. And this is same thing which is shown here in the normal right hilum picture. That is the superior pulmonary vein. This is the hilar angle. This is what is constituting, along with pulmonary artery, the hilum. This is also applicable in case of left hilum. So I will not go into this kind of details. So on PA view, each hilum has a branching vascular appearance. 1/3 of the vascular density is in the upper half of the hilum, and two-thirds is in the lower hilum. This will reflect the distribution of blood flow to the upper and lower halves of the lung. The right paratracheal strip is less than 5 millimeter wide. The right paratracheal strip is less than 5 millimeter wide. And when we see the lymph nodes of the hilum, normally the lymph nodes in the hilum are inconspicuous and they are not demonstrable as separate unit on chest X-ray or non-contrast CT. Lymph nodes in the right hilum are divided into four groups: right upper lobe, descending right pulmonary artery, middle lobe, and the lower lobe. And in the left hilum, the lymph nodes are further classified into left upper lobe, descending pulmonary artery, and lower lobe. So the hilar point measurement, as I already told you, now what are the criteria which is used to evaluate the hilum? One is the shape, that is a branching vascular appearance, which is normal. Number two, radio opacity. Normally, if the radio opacity gradually diminishes towards the periphery, two-thirds of the vascular density is in the lower portion of the hilum. An absolute size not reliable unless the enlargement is considerable. So we have to compare the left and the right side for the symmetry. Causes of the hilar enlargement: lymphadenopathy and tumor, rounded non-branching structures in which the radiopacity abruptly diminishes at the margin of the tumor in cases of lymphadenopathy, pulmonary venous hypertension, enlargement of the superior pulmonary vein. It causes increased vascular density in the upper half of the hilum due to LVF, mitral stenosis, or mitral regurgitation. Pulmonary arterial hypertension, central primary pulmonary arterial hypertension, and lung diseases due to COPD. Increased pulmonary blood flow, increased central and peripheral pulmonary vascular marking due to left to right intracardiac shunt and hyperdynamic circulation. So hilar mass this is an example of hilar mass which is seen on the lateral view. So whenever you are seeing the hilar overlay sign or to always look at the lateral view, and this is where the lateral view's importance still lies. So what are the causes of hilar lymphadenopathy? Asymmetrical, EB, fungal, metastatic or primary hilar tumor, lymphoma, sarcoidosis. And bilateral symmetrical causes are sarcoidosis, viral infection, other causes mentioned above. They can also be symmetrical. An approach to a patient with unequal hilum: clinical, pathological, and radiological. So how to approach the hilar mass or lymphadenopathy? Age. In an elderly individual over the age of 50 years, it will favor the diagnosis of malignancy, whereas in pediatric age, the hilar lymphadenopathy supports the diagnosis of TB. Duration of illness, occupation, smoking, presence of constitutional symptom. These symptoms in lymphoma, although they do not rule out tuberculosis, other malignancies. Presence of hemoptysis, progressive shortness of breath favors the diagnosis of bronchogenic CA. Hoarseness of voice will favor the diagnosis of malignancy. Compressive symptoms like dysphagia, SBC syndrome, dyspnea occur in presence of mediastinal lymphadenopathy. Presence of arthralgia, abdominal pain, eye symptoms, hypertension, skin rashes will point towards sarcoidosis. Asymptomatic detected during screening or preoperative examination may point towards sarcoidosis. However, no history is specific enough to conclusively prove a diagnosis. Skin, these are all skin manifestations of sarcoidosis. So factors, this I will not go into the details. So I will show you certain cases and that how to what are the causes of enlargement of lymph node in CT, classically seen in Castleman's disease. Hypervascular metastasis seen in melanoma, renal and thyroid carcinoma. Mild enhancement is seen in EB, fungal infection, lymphoma, metastatic lung cancer, and sarcoidosis. And significance of necrosis in the lymph node, low attenuation areas in the lymph node will suggest necrosis. These are seen in TB, fungal infection, lymphoma, Whipple's disease, metastasis from the lung, testis, and ovary. Calcification in the lymph node, prior granulomatous diseases, TB, histoplasmosis, sarcoidosis, silicosis, metastasis in osteosarcoma and prostatic CA, post-radiotherapy in lymphoma. Dense hilum sign, as we all know, hilum overlay sign, hilum convergence sign. This is an example of contrast enhanced pulmonary CT angiography in a 43-year-old man showing the pulmonary thromboembolism. This is shown in heart failure where there is a full fuzzy hilum. These are all examples of heart failure. Heart failure before and after treatment, you can see the hilar oval shadows almost disappear. These are nowadays PET scan made our job much easier to identify whether the hilar enlargement or hilar lymphadenopathy is pathological or physiological. Hilar lymphadenopathy in tuberculosis is generally not associated with hilar lymphadenopathy. In adult, TB is usually due to reactivation of prior disease characterized by multifocal cavitary infiltrate in the upper lobe, panorama formation, and healing with fibrosis. Primary TB, classically described in children, causes a lobar infiltrate, which is indistinguishable from the pyogenic pneumonia and often hilar lymphadenopathy. These are all primary complex tuberculosis signs. Asymmetrical hilar lymphadenopathy in TB. This is a case of 25-year-old male who presented with fever and cough for 3 months. We can see the necrotizing mediastinal lymphadenopathy, which is classically seen in TB. This is a 58-year-old man with 6-month history of cough living in America. With similar kind of history, we will think of the histoplasmosis. So it is not the radiological appearance, it is the history which in many cases will give you a clue to the diagnosis. 2 patients with same history but living in India, tuberculosis, an American soldier working in Vietnam presenting with this kind of CT will have a diagnosis of melioidosis, and a 62-year-old diabetic presented with this kind of thing with a parrot shop employee, he will have a diagnosis of psittacosis. A 50-year-old male with a 30-year exposure of silica, this is also a classical appearance of eggshell calcification of hilum, caused due to silicosis or tuberculosis or both. A 35-year-old patient presented with low-grade fever and cough for 5 months. Bronchial mucosal biopsy confirmed the diagnosis of sarcoidosis. A 35-year-old man with a past history of TB with increasing cough for last 4 months and shortness of breath for last 2 months with those erythema nodosum will have a diagnosis of sarcoidosis. A 65-year-old patient presented with hemoptysis with progressive SOB with a diagnosis of bronchogenic CA. A 63-year-old patient presented with persistent progressive shortness of breath, CT-guided FNAC and TrueCut biopsy confirmed the diagnosis of adeno-CA of lung. A 50-year-old female with a 3-month history of cough will history revealed of mastectomy, which was done for a breast cancer 2 years ago. So it is important to have a look at the chest X-ray very carefully before commenting. So with a mastectomy history, with a lymph node enlargement, you will obviously think of some kind of metastasis. This is another 56-year-old female presented with an MMRC grade 4 SOB, again with a history of mastectomy with similar kind of lymph node enlargement. This is another kind of imaging nowadays not done, bone subtraction imaging showing mass in the right hilum. This is a 24-year-old woman presented to the emergency department with exertional dyspnea, chest tightness, and lightheadedness for 3 weeks for dyspnea on exertion. On the day of presentation, she fainted while running up of a flight of stairs. We can see the hilar enlargement. This is classical primary pulmonary hypertension. This is the lateral view in pulmonary hypertension. This is a 30-year-old patient presented with a frequent history of respiratory tract infection and progressive shortness of breath, and echocardiography confirmed the diagnosis of atrial septal defect. This is a 46-year-old male presented with a deep throbbing chest pain, back pain with shortness of breath. Again, a diagnosis of aortic aneurysm. 22-year-old male presented with signs of heart failure. This is figure 1, this is figure 2. And you can clearly see the diagnosis of pulmonary stenosis. So it is the variety of picture. A 35-year-old female with respiratory failure. Again, we can see a diagnosis of thymoma with myasthenia gravis. A 20-year-old presented with cataract. During evaluation of cataract, a chest X-ray was done. Further investigation confirmed diagnosis of neurofibroma. Presented with 4-month history of fatigue, dry cough, low-grade fever, swollen axillary cervical lymph node, and Castleman's disease with LIP diagnosis was made. A 38-year-old female presented with a cough SOB for last 3 months following silicone implantation, rare diagnosis of silicone-induced lymphadenopathy proved by mediastinopscopy followed by biopsy. A 45-year-old male presented with 7-month cough, 3-month SOB, and again a diagnosis of pulmonary lymphangioma was made. Thank you. Now we will go to all the panelists for having their opinion, and also we will take all the questions from the audiences. Yeah. So to go through all of our individual panelists one by one, so I will first go to, so Dr. Mayib has joined already. Dr. Satish?
Joined.
There.
Yes,
Good
yes. Okay, so I will go to one by one panelist, and I will request each one of the panelists also they may intervene at any point of time when the question will be asked to other panelists, because this is open, and at the same time we will take the questions from all the audiences one by one. So to start with, I will go to initially Dr. Shweta, and I will ask her, so what are the components of the normal hilum? What are the things? What are the vessels, or what are the lymph nodes? What is the constituent of normal hilum? And is there anything which is appreciable in the radiology, distinguishable by the anatomy? Suppose what I want to ask you, that whether in chest X-ray can we, or in the CT scan, can we appreciate the constituents of the hilum each by one? Dr. Shweta.
Sir, as we had already seen in the presentation, the hilum, it constitutes mainly of the bronchus. In the left hilum, we are having only one principal bronchus. In the right hilum, we are having two bronchus, which is hyperatrial and the epiatrial bronchus. We are having the pulmonary veins as well as the pulmonary arteries, which constitutes the hilum. Apart from this, there is correlation with the phrenic nerve as well as the lymphatics with the hilum. Radiologically, we can see that the left hilum is somewhat at the higher level than the right hilum, but because even because of the rotation or the malposition of the patients, we may sometimes get this inequality of both the hilums. Pulmonary vasculature is much more appreciable in the chest X-rays rather than any other structures which can be seen in the X-ray.
Doctor, to ask you another thing, that whether the artery and vein, this can be appreciated in the CT scan. What is your appreciation of hilum both in X-ray as well as CT?
So that's what I say, that the vessels are much more visible.
I will also go to Dr. Nikhil. In this part, that whether from a many a times we used to say these are the lymph nodes, which are, but whether it is possible to comment anything from the CT or from the chest X-ray regarding the constituents of the normal hilum, also regarding the vessels.
So this superior pulmonary vein is seen in the higher side, and the inferior pulmonary vein is seen in the lower part. And 2/3 of the vessels are present in the towards the lower part, because the blood flow is much more in the lower lung part rather than the upper lung part.
Yes. Okay. And Dr. Nikhil, do you want to add anything to Dr. Shweta?
On chest X-ray, good evening everyone. On chest X-ray, it is generally very difficult to comment whether it is a vein or an artery. On CT, on plain CT, it becomes a little clearer, and on contrast CT, it is very clear which is which. So,
Dr. Nikhil, also from a radiologist point of view, when you do not have any kind of history written, for every purpose chest X-ray is written. So what are the things which we need to keep in our mind before commenting about the hilum regarding rotation or all those things? What are the things which you, as a expert in this field, you will recommend to all of our attendees to keep in mind before commenting upon or before straight away jumping to the CT scan?
first of all, the X-ray should be, there should be no rotation, and bilateral hyla are generally similar in density. So if we see an unequal hilum, that is, one hilum is more dense or less dense than the other, then we require further investigation.
And apart from the rotation or those kind of thing, any other factors which will result in false impression of any hilar pathology?
Any calcification of vessels.
Okay.
Any
other things? So this is a very important point what Dr. Nikhil has already highlighted, especially in the elderly individual. As we all know, they may be having atherosclerosis. So many a times you will be having an impression of a calcification of the aorta or the big vessels, which may mimic as a false shadow in the, or may lead to do the CT scan. But still, will you recommend for any kind of confusion in any kind of hilar impression in the chest X-ray, do you straight away recommend CT scan, contrast CT scan? Or in many cases, you will go little bit slow or ask for a repeat X-ray before proceeding for a CT? Or whether it will depend upon you will refer it back to the pulmonologist or the clinician who has asked for the chest X-ray. So what is your advice regarding that?
The three important signs of hilum are dense hilum, hilum overlay sign, and
that I will come later on. Just I'm asking from whether you will straight away go to the contrast CT or you will wait for a repeat chest X, or it will depend upon what you are getting.
For example, in pulmonary edema or cardiac causes of hilar enlargement, right? We generally can wait and refer the patient back with our findings, and then we can repeat the X-ray. If it is similar, then we can go further on CT.
Okay, agree. So now I will go to Dr. Tridib Chatterjee, sir. And sir, is there any differences in the constituents of the left and the right hilum? That what are the vessels which are coming to form the hilum in the left and right side? And is there any specific reason behind the difference in the positioning of left and right hilum, which is related to the constituent, or whether it is an anatomical variation, and whether that anatomical variation is present in every individual or not? So Tridib, sir.
Thank you very much, and thanks for this one topic and getting invited for this very unique thing. So your question is very, Vijay, can I have the first slide, please? So I have taken from your slides only, which you have prepared very well. So you have clearly shown that the hilum is basically mainly made by the bronchus, this pulmonary artery and the pulmonary veins on both sides, the ligament. Now, the bronchus which is there is usually not seen in a normal X-ray. I mean, it's very rarely seen, nor is the lymph node normally seen. The main part of it, can I have the second one, please, Vijay? As you have shown here, that the main part of it is formed by the pulmonary artery. But on the right side, generally the hilum looks a little bigger because either the bronchus is bigger, or there are sometimes two bronchi. The bronchus appears a little bigger, so hilum appears a little bigger. But by and large, in about 90-95% of the cases, the left hilum is a little higher than the right hand. But this is not a universal rule. It can always also be it can be also at the same level. But usually 95 or 97% of cases, Usually it is because of the positioning of the bronchus. So as Dr. Shweta already said that the bronchi on the left side are divided into three. So here only parts, because of which the hilum gets a little pushed up in some cases, and you may get the left hilum is slightly little more higher than the left. Next slide, please, Vijay. And as you showed in your X-ray, that the branching, the vasculature which is forming the main part of the normal hilum, which is on the X-ray, it is having a branching vascular pattern. Most of it is the blood flow mostly downwards, and then 1/3 of it is showing upwards. And then the small paratracheal shadow. So by and large, the constituents are more or less the same, but except that the left hilum is a little pushed up. Sometimes, most of the time, a little above the right side. That's about, in the normal case, that is what it is. Thank you.
So thanks, Tridib sir, for wonderfully describing what are the differences between the left and right, and how to interpret in normal day-to-day chest X-ray of the difference in position of the left and right. So now I will go to Dr. Nikhil again, and I will ask him about the hilar angle and the hilar point. So what do we mean by the hilar angle and hilar point, and how to interpret this on normal chest X-ray as well as in the CT scan? And what is the normal hilar angle in normal individuals?
Right. So thank you for the question. The hilar point is what we describe as a purist's view in X-ray. So it is a point where the pulmonary, lower branch pulmonary artery crosses, or the upper branch pulmonary vein crosses the lower branch pulmonary artery. The point which is very difficult to see on a X-ray, but in some cases it can be seen clearly. So that is a hilar point. So to see where is the hilar point, we go by this hilar angle, which is identified as the lower lobe pulmonary artery at its lateral border, where you can see any vessel crossing upwards to upper lobes. So
it will be better, I think, if you share for everyone, for the common audience, and it will be easier for Dr. Nikhil to describe, I think, hilar point and hilar angle. If you just show the Tridib sir immediately the PPT, that hilar angle on the chest X-ray, it will be better for the audience, I think. It will be helpful for Dr. Nikhil to describe the hilar point and hilar angle, possibly from that picture, I think.
Okay.
So will it be possible to share that PPT?
Wait.
That Dr. Tridib sir has shown just right now.
I think Bijal, you can show the second one. Yeah.
Yes,
Next. This one and the next one. These two you can show it.
Yes. Now, Dr. Nikhil, you can describe. So what are the constituent and how to measure the hilar point and the hilar angles, all those things?
So my cursor,
will it be helpful for you to have the chest X-ray view? The next slide?
Actually,
this one, I think, will be helpful for you.
Yeah, in this X-ray, but no one can see my pointer, that is.
Okay, but just from a brief description, at least they have a picture.
Yeah, you can tell. I can just show like this. You can just say Nikhil if you want.
So
if that will help.
Here there is written 1/3 and 2/3, right?
Yes.
So the straight line between these two,
yes,
is the hilar point where they meet.
Where I'm
Yes.
moving the pointer. Okay.
And the 1/3 diagonal line and 2/3 diagonal line is generally the hilar angle. This, okay, I can't explain it like this, but
No.
uh,
So, Mane, you have described it brilliantly. So, it is the
So,
angle between the 1/3 and the 2/3. No?
right.
okay. So I think this angle, what you are saying, right?
Yes. Yes.
Okay, great. Go ahead, go ahead. I will try and help you from here. Go ahead.
Yes. Yes.
Mm,
Dr. Nikhil, go ahead.
yeah. So the point of crossing these forms a horizontal V-shaped structure. That V-shaped structure is higher on the apex of the left hilum should be higher than the apex of the V at the right hilum.
Yes.
In 5% cases, it may be in the same level, at the same level.
So, how to, as we all know, now we can stop sharing this PPT. So now I will ask a question both to Tridib sir as well as to Dr. Nikhil. Now, many times in absence of even collapse signs, like in absence of fibrosis, so if we see the hilum is situated higher up, it may be a constituent of the anatomical variation rather than just directly commenting whether the patient is having some signs of collapse or fibrosis. Because to be presence of collapse or fibrosis, the signs of fibrosis must be there in the chest X-ray or CT scan, and also collapse signs must be present on the chest X-ray. Just because the hilum is pulled up or hilum is pulled down, it doesn't mean fibrosis or collapse. So that message, I think, Tridib sir as well as Dr. Nikhil, it should be loudly presented to all the audiences. I think so.
Yeah, I think see here, Dr. Debraj, I think you just see an X-ray, and Nikhil doctor, he may be just sort of handicapped because he gets only the X-ray.
Yes,
But
because
for,
of that fact.
but for people like us, we just cannot just see one X-ray and say, oh, your hilum is up. You have to just go into the history. There is patient has a cough, or he's had TB in the past, he's had some symptoms, or you try to get his old X-rays, you might find the same thing in his old X-rays. So that will sort of give you that's it, okay, that's an old shadow that's there, forget about it. Nothing is to be done. So you cannot make just because the hilum is there, oh, you go for all CT scan and bronchoscopy, amoebas. No. That is certainly not the way. And I'm sure Nikhil also would agree on.
Yes, sir. Also, the left hilum is generally higher because the superior margin of the the left main pulmonary artery, which passes over the left main bronchus, and the right main pulmonary artery passes in front of the right main bronchus. So the left hilum is generally higher, or it may be
So
at
I
the
will
same
take
level.
Yes. So I will take two questions from the audiences and then I will go to Dr. Sudhindra Raghu. So there is a question by Dr. Harendra from Ahmedabad. He has asked a wonderful question, very specific question. What do we mean by hilum prominence? Because in chest X-ray, many a times it is written as hilum prominence. So what do we mean by hilum prominence? Is there any term called as hilum prominence in radiology? And if this is a term, then how do we define the hilum prominence? Or it is a subjective term by a radiologist?
So hilar prominence is generally when one hilum is more prominent than the other.
Okay, so it is a comparable term.
Yeah. So we compare the both hilum. Generally, there is
in respect to each other.
Yeah.
So in cases of sarcoidosis or those things, when both the hilums are enlarged symmetrically, then how do you say hilar prominence?
Then the generalized shadow and the hilum is generally lumpy, bumpy in appearance, and there are other signs of hilum.
Okay. So any of the panelists, whether they want to add anything to what Dr. Nikhil has said?
I just want to add here that which I think Dr. Nikhil can expand. The rotation of the film must be seen, because if the patient is, that is essential to, if it is rotated, automatically it will appear prominent, and then you must just bark up the wrong tree. So I think that technicality of the X-ray should be done properly, especially if it's a standing PA X-ray.
Okay. Another question from Dr. Krishna Kumar from Vadodara. So he has also asked a brilliant question, whether I will go to Dr. Sudhindra thereafter, that whether inspiration and expiration help in identifying, whether the inspiration and expiration will make any change in identity.
Dr. Debraj,
I'm repeating my question again. Dr. Krishna Kumar from Vadodara has asked a question, whether inspiration and expiration will help in identification of vessels or arteries, or whether in general they will make any change in interpretation of hilum, the inspiration, role of inspiration and expiration. Dr. Nikhil?
Yeah.
Because I am coming for all the anatomical and radiological questions to you, because you are the best person to give an answer.
On expiration, generally it will be more prominent.
Okay. So is there any requirement of, like, all the chest X-rays, it should be done at the end of expiration, like those things?
Generally, if there is a confusion.
Okay. So now I'm coming to Dr. Sudhindra Raghu. Sir, many a times we all know, whenever the hilar enlargement comes to our mind, usually we think about hilar lymphadenopathy, barring some few causes of the related to vessels or all those things. We all think about hilar lymphadenopathy. We should all be honest with each other. So what are the normal lymph node size, and when to call it that the lymph node is pathological, and whether all the enlarged lymph nodes are pathological? So what are the normal lymph nodes of hilum, and whether they can be, or they can seen or appreciable in chest X-ray or CT scan? Regarding the lymph nodes, I think the most important thing of hilum is the lymph nodes.
Normal lymph nodes in hilum are inconspicuous and are not demonstrable as a separate unit on normal chest X-ray or non-contrast CT scan. If it is enlarged, then we can demonstrate either in X-ray or in contrast CT or CT. So most common cause of lymphadenopathy is, in our country, is tuberculosis. In tuberculosis, post-primary is the most common cause, and it is mostly present in pediatric and adolescents. If it is present in adults, then we must think of immunosuppression like HIV, other things. And other second most common cause is bronchogenic carcinoma. Due to bronchogenic carcinoma, secondary to bronchogenic carcinoma, lymph node may enlarge. And third is lymphomas. Lymphomas present with peripheral lymphadenopathy also. If it is not present, then the doubt arises. And the most common cause, bilateral, is sarcoidosis. Other less common cause of fungal, atypical mycobacteria, viral, tularemia, anthrax, like that. And silicosis, drug interactions may not be present.
Yes, Dr. Raghu, I will go one by one. So what are the normal size of the lymph nodes after which we will describe in the CT scan as an enlarged lymph node? Is there any size? In CT scan, to call a lymph node enlarged, is there any particular size which is written or mentioned in the literature? That above this, you can call this as a pathological lymph node?
Not specific like that. More than 10 mm, which you take it as mostly pathological.
Yes, yes. And any particular location where, like hilar or subcarinal, where you will call, because we are talking about hilum. So whether hilar lymph nodes has a specific importance compared to the subcarinal or the paratracheal lymph node, or is it applicable for all? Because many of the literature used to say that hilar lymph nodes are very specific. So is there anything, or it is like other lymph nodes or like subcarinal or paratracheal, those kind of lymph nodes, in your knowledge or in possible literature?
Unable to catch.
I would like to add here.
Yes, Dr. Nikhil.
First of all, the size which is significant is 10 mm in short axis diameter. And the lymph nodes are generally 1 centimeter, mostly all the lymph nodes except axillary and inguinal, which are 1.5 centimeter in short axis diameter. This is as far as I have read the literature.
Excellent. So now I will go to Dr. Tridib Chatterjee, sir, again. Sir, being a pulmonologist, when we are sitting in the OPD, it is not possible to measure all the sizes of the lymph node, or many a times, in the peripheral centers, the report by the radiologist may not be that expertise as Dr. Nikhil. So from a pulmonologist point of view, how to define hilar enlargement, when we should think of having in a possible history also. So how to define hilar lymph enlargement from your long experience?
So we are back to, I hope I'm audible. Yeah.
Yes, sir, you are audible, sir.
Yeah. So we are back to what forms the hilum. So as you said, most of the time it is arteries and the lymph node, which are generally not seen. So most of the time, which is, as you rightly said, it's the lymph nodes. So the lymph nodes generally are rounded, they are non-branching, which generally abruptly diminishes at the margin. That is generally what the lymph node or the tumors are. Of course, the lymph nodes are, we are talking about hilar, but by and large, when you get hilar, you generally tend to get other nodes also. It's very rare to get just a hilar node and not a paratracheal node or subcarinal. Usually the nodes are almost always, other nodes are also involved, at least on one side. But in addition to the lymph nodes, other things which are also there, which when more can cause enlargement. One is the venous. That is like in diseases like left ventricular mitral stenosis, you will find the superior pulmonary veins which will be enlarged. Now, normally it would be said that the vasculature in the upper side is less, but in left ventricular failure or mitral stenosis, so the veins become very prominent, and even on a plain X-ray, sometimes you can, especially if patient is taken erect, even in erect position, you can main part is the pulmonary artery. So the size of the pulmonary artery, central pulmonary arteries are dilated. Now the normal pulmonary artery size is the main pulmonary artery size is about 25 to 30 millimeters. That is if you can measure it. So, but after certain period of time, you roughly know from yourself, but in a scan you can actually measure it. So when it is enlarged beyond that, and usually along with that there is also evidence of right ventricular strain or right ventricular heart is enlarged, then this will give you an idea that the hilar enlargement is because of pulmonary arterial hypertension. And the last is the increased pulmonary blood flow, which happens because of increased shunts, like where there's a high output failure. For example, thyrotoxicosis. For example, when there is severe anemia. There, in addition to the hilum, you will see peripheral central vascular shunts towards the peripheral part of the lung, where you will see this vessel which you normally would not see. These all together, but of course, out of this, most of the time it is the lymph nodes and the tumors. But yes, you have to also be aware that these other, the vasculature, the arterial as well as the venous, can also be part causes of a hilar enlargement. Thank you.
So wonderful, Dr. Tridib, sir. Now I will go to Dr. Shweta. As Sarah has already mentioned about the causes of the hilar enlargement. So in your experience, what are the 3-4 most important causes of hilar enlargement?
The causes for the hilar enlargement can be divided into what are the structures which are already present in the hilum. Whether it can be because of some lymphadenopathy or tumor or some vasculature involvement. So the causes for lymphadenopathy or tumor involvement, it includes various infections like tuberculosis is most common in India, or histoplasmosis in American states, or in Vietnam you get melanosis. Apart from it, there are certain other infections like atypical mycobacteria. You have fungal infections, viral infections, then various malignancies like bronchogenic carcinomas, metastasis from various organs, as well as lymphomas may lead to lymphadenopathy or tumors. Apart from it, pulmonary artery hypertension can also lead to hilar enlargement. It can be primary or secondary due to lung involvement, such like in COPD or ILDs, secondary pulmonary artery hypertension. Then the pulmonary venous hypertension, it may be due to some cardiac diseases like left heart failure, then mitral regurgitation, mitral stenosis. All this will lead to increase in the pulmonary venous hypertension, and this will lead to hilar enlargement. Apart from it, pulmonary vasculature, if there is a hyperdynamic flow or there is left to right shunt in the heart, then also it may lead to hilar enlargement. So these are the most common causes for the hilar enlargements, what we can differentiate.
So now I will go to the again, Dr. Rangu. Sir, many a times in real life experience, in any of the causes apart from hilar lymphadenopathy of hilar enlargement, because the vascular causes are very rarely seen. So, in which are the conditions you will look for the vascular conditions or causes of the hilar enlargement apart from the hilar lymphadenopathy, even from the history? When you think of different things apart from the hilar lymphadenopathy of hilar enlargement, from the history, what are the points you will look for, or which will make you search for the other causes of hilar enlargement?
Patient present to us with fever, weight loss, or hemoptysis, then we should think in terms of lymphadenopathy, etc. If we are presenting with breathlessness, more on lying down, orthopnea, then we should think in terms of vascular organs. Then we must evaluate in different way. To the echo like that.
So before now going to our oncologist, Dr. Satish, I want to congratulate all of the panelists as well as CCI for, because of the fact that already more than 1,000 logins have been done, and I will request more and more audiences to join, because this is a very unique topic which you will not find in your day-to-day discussion, because every day we are having some discussion on obstructive airway disease intervention, ILD, or those kind of things. But our basic route regarding the radiology and in our day-to-day OPD practice, so today we are talking about this aspect. Now I will go to our oncologist friend, Dr. Satish. So what is the importance of the hilum to an oncologist? This is my first question. What is the, how do you look at the hilum? Is it like the any other lymph node stations, or does it carry some additional significance? Or always you need to write the PET CT scan, or sometimes even the chest X-rays, particularly I am talking about other malignancies, like suppose breast malignancy or malignancy of the body. So do you routinely prescribe PET CT, or many times even chest X-ray may be sufficient when you have a reasonably normal chest X-ray?
So thank you everyone for giving me this opportunity. So I'll come to the first question. Generally, sir, the hilum and the mediastinum is very important structures to us, because most of this lymphomas, they'll start, the first presence will be at the hilum, the lymph nodes which you can make out at hilum. And we have primary mediastinal B large cell lymphoma, where we can, many a times we have seen on X-ray only, there is a mediastinal widening, and there will be prominence at
Dr. Satish?
Thing is, internet is not stuck.
Dr. Satish is not possible. possibly because of the poor connection.
Yeah, he's come.
Dr. Satish?
Yeah. Can you hear me now?
Yes.
Yes. Now you are audible.
So, sir, the hilum is a very important, like hilum and the mediastinum is a very important structure to us because see, most of the lymphoma they'll start with the first presence, like primary mediastinal B cell lymphoma. The first thing which we'll see is mediastinal widening. Now, apart from hilum, when we have this asymmetrical hilar enlargement, we think of malignancy. When symmetrical, I think it is more of a inflammatory cause like sarcoidosis. So whenever we suspect, like many patients who have come with a cough, we have just asked an X-ray with weight loss, and from there we have done CT scan. And many times, yes, we need a PET scan when we are suspecting lymphoma. Structurally, we may not need a PET scan, but then we have a FDG. We have to know whether the lesion is FDG avid or not. Because when we are declaring a lymphoma patient cure, then the size should go both structurally also and through the FDG avidity should also come down. So in that way, we need a PET scan. Second, the squamous cell carcinoma, generally they will come with unilateral hilar mass. And many a times we have this hilar when they are present on the right side. Many a times because the lymph nodes are there in mediastinum or the hilum, we'll go for the CT guided biopsy from there.
So, in which case, will you be just satisfied with the chest X-ray? Is there any case? I don't think so. From an oncologist.
No, sir, we won't be satisfied with the chest X-ray because we need very thin section to know whether there is any micromets or not.
So
sir, Dr. Debraj, one question I want to ask you. So,
yes.
I mean, suppose on a X-ray you see something, a lymph node, and you think maybe lymphoma.
Yes.
Do you do a first CT and then you do a contrast CT and then do a PET CT, or you might directly do a PET CT? I'm asking you because in case financial issues are raised.
Sir, from a pulmonologist point of view, I will definitely go a contrast enhanced CT. I cannot just write down PET CT scan, sir.
Yes, sir, but from my point of view, sir, if I find a hilar enlargement, and if the patient is not financially, he's not financially well off, and when I'm not finding any other B symptoms, then I will explain in the best investigation will be PET CT. But then
sir, that is in a case of proven malignancy. But like Dr. Tridib sir or me,
I'm talking about something which is unproven.
Unproven case. So unproven, it is very difficult to straight away jump to PET CT scan. Ordering a 35,000 rupees investigation.
No, sir, we will first ask for the symptoms, whether the symptoms are matching, like whether any B symptoms are there or not. Fever, weight loss, and apart from that, that malignancy, that hilar enlargement I'm seeing. Suppose if it's asymptomatic, comes with a hilar mass, I will never go to PET CT, I'll go for a CT thorax.
Dr. Satish, the problem is that in our pulmonological practice, many times tuberculosis, sarcoidosis, they will present with similar kind of symptoms, particularly tuberculosis. So in a tuberculosis endemic country, just for suspecting tuberculosis itself, we cannot straight away go to PET CT scan. So from my perception, that in a proven malignancy patient, we should definitely go for whole body PET CT scan to be straight away know where are the lymph nodes, which is the most accessible one, whether we need to restage our disease. I absolutely agree with you. But from a pulmonologist sitting in an OPD, seeing an enlarged hilum, even in presence of fever, even in presence of night sweat, even in presence of loss of weight, we need to rule out tuberculosis at first. And for ruling out tuberculosis, I think best test, even in many of the settings where the giving contrast is a little bit difficult, or you are in a hurry to have a diagnosis, a simple CT scan thorax may be sufficient in many of the cases. When you see Suppose you are unable to appreciate the cavity in the radiology because of the peculiar location of the cavity. In a CT scan, you may be, it is possible to see the cavity with the twin buds, with that now the lymph node. So the diagnosis may be obvious in many of the cases. But I agree with you also, whenever we are suspecting malignancy or in a proven case, it is always better to do the PET CT scan, because in the PET CT scan, we can also have a look of the CT scan. So this, I think this should be the message. I will again take the opinion of all the panelists. Anyone?
So, sir, I'll agree with you. Whenever I'm suspecting malignancy, then only I'll go for a PET scan. If I'm not, then CT thorax with contrast is more than enough. This, apart from these symptoms, I'll also look for whether any other lymph nodes are present, any neck nodes are there, where any severity of weight loss is there, whether the person comes from endemic, non-endemic zone. So that all will be taken into consideration. But suppose I'm not suspecting malignancy, a CT thorax will be good enough for me.
Okay. So now I will go to Dr. Shweta. How do we approach a patient or a radiology of hilar enlargement by history-wise? So if you ask just 5 points in the history, sitting in the OPD or any of our students who will be appearing in their postgraduate exam, the simple MD or DNB fellows. So what are the things in history which we should ask the patient, or whether we should look for, even the negative points in the history which we should look for when we have a chest X-ray or CT scan of hilar enlargement, be it hilar lymphadenopathy or other causes of the hilar enlargement? In points in the history.
So thank you for the question. Taking a proper history actually narrows down our differentials. So taking proper history of any patient in which we have an enlarged lymph node is very much important. First of all, we see the age and sex of the patient, because diseases like tuberculosis is much more common in young patients and CA is much more common in the older patients. So we'll see for the age, the onset of the illness, sex, then whether the patient is having a history of smoking, because if the patient is a smoker, there are more chances of malignancy. And if it's a non-smoker, there are more chances of sarcoidosis. Apart from it, we will have to take occupational history, because even diseases which may lead, occupations which may lead to silicosis, we may find hilar enlargement. Apart from it, travel history is very much important, because certain infections are common in certain geographical regions. Like if the patient is of India, tuberculosis is the first differential. If the patient has a history of traveling to America, then there will be chances of histoplasmosis. Or if Vietnam, then there may be chances of malidosis. Apart from it, we will ask for the general symptoms. What are the symptoms? Whether the patient is having any low-grade fever, night sweating, weight loss, anorexia, or grade B symptoms. So we'll look into all those symptoms. So this is the main points we'll cover in the history, and then we'll proceed for the clinical examination.
May I add here that occupation also is a little.
Yes,
I mean,
Occupation.
that is again something which might, if it's silicosis and all that,
yes.
which is, that might also help.
Very typical appearance of that silicosis. We all
So
know
that's
that.
why our occupational history is part of what doctors, or other things, or everything else she has told actually nicely.
Yes, absolutely. So now I will go to Dr. Nikhil. We all used to do the contrast CT to also have an idea whether the lymph node is enhancing or non-enhancing. So very important point, whether we should give any importance to that point, enhancing or non-enhancing lymph node. How do we define necrosis in the CT scan, and whether it will help to achieve any diagnosis, or whether it will not help in diagnosis? Anyway, we need to confirm it by the cytology or the histopathology. So what is your take, Dr. Nikhil, on enhancement and necrosis?
That is a very interesting question. Thank you for that. First of all, let's go on to necrosis. Necrosis is something which we see as a hypodense area, which is non-enhancing on contrast CT. right? In a lymph node, which is peripherally enhancing with central non-enhancing area, generally it is necrosis. Second of all, the lymph nodes which enhance are generally tumoral lymph nodes or metastatic lymph nodes. Lymphoma enhances to a lesser degree, and the tubercular lymph nodes are generally showing necrosis within.
So, how do we define by Hounsfield unit how do we define necrosis? Is there anything by the HU?
The HU
or it is the visible appearance?
Mostly it is visible. The HU is that of a soft tissue.
Soft tissue. And apart from tuberculosis, any other causes of necrotizing lymphadenopathy? Can malignancy present as a necrotizing lymphadenopathy?
Yes, metastasis can present as necrotizing, but it is generally the enhancement will be higher than a tubercular lymph node. And fungal infection.
So whether the enhancement of the walls, or you are talking about the surrounding structures?
Of the
wall of the
node. Periphery of the node.
Periphery.
The necrosis will generally be central.
Yes, yes. So any difference in the necrosis of tubercular and the malignant lymph node?
Necrotic material is generally similar.
Generally.
Pathologically, it can be differentiated in case.
So there lies the importance, because nowadays when you have a necrotizing lymphadenopathy, just because you have a necrotizing lymphadenopathy, you cannot stamp the diagnosis of tuberculosis. You need to confirm it by plain conventional TBNA guided cytology, or EVAS guided TBNA, or EVAS guided cryobiopsy, or by sending the gene expert, but you need to confirm the diagnosis. Necrotizing lymphadenopathy just give a simple clue, but it is not confirmatory. You need to have the issue for the confirmation of diagnosis. I think everyone will agree on this point, right?
Definitely correct.
Absolutely. So now I will go to Dr. Tridib Chatterjee sir again. Sir, we used to give a lot of importance to the calcification. This is unlike necrosis, you will also agree. Just having calcification many a times is actually assuring for all of us that it is not that harmful. We need not to do anything particular when we see calcification. So what are the causes of calcification of the lymph node? And second point, Tridib sir, what I want to ask from your day-to-day practice. So when you will opt for some particular test or tissue diagnosis, even in a calcified lymph nodes?
That's a great second part question, is also very interesting. So as you said, the calcification, as I've already said, tuberculosis, all of us by now have been repeating this. The tuberculosis in our country, tuberculosis lymph nodes are the commonest, and generally they heal by calcification. You must not only in the lymph node, but even on the pleura, even on the parenchyma, you will see calcification. So generally there is. So by and large, a prior granulomatous disease, of which tuberculosis becomes the number one in India. So histoplasmosis in certain areas. Sarcoid can also calcify. However, it is only in 25%. Silicosis we have mentioned, which is a very typical eggshell calcification, which I think that you had shown in your presentation very nicely. With the peripheral part of it, just like the egg, the peripheral part of the nodes get calcified. And of course, you will get the history that the patient has been exposed to silica by doing. But in addition to these supposedly benign conditions, you can have the metastasis in osteosarcoma, prostatic carcinoma, post-radiation lymphoma, which can also be calcified. And there are some uncommon causes which are not common, but you should be aware. One is pneumocystis, BJP, metastasis from thyroid carcinoma, amyloidosis, Castleman's disease, and scleroderma. So these are the general causes of calcification. But as you said, as you asked me the second part, just because you have calcification, it is not good enough. You must try to find out from the clinical history if the patient has had any history of the uh, anything suggestive of infection. If we can, you have to try your best to try and locate an old X-ray. Just seeing a similar X-ray in the past where there was where the similar calcification is there can kind of give you. You don't have to go for a scan. That can just assure you this is something which is there. So history, seeing the old X-rays, trying to get into the details of the occupation, all this will give us some idea. And if there is an evidence, like as I mentioned, there is an evidence of metastasis. So there will be some severe weight loss. There will be prostatic cancer. There will be something in the prostate area which is a PSA will be raised. So these conditions you can't just pass it off. Oh, it's calcification and nothing. You have to then investigate the patient just like you would, even if there was no calcification. So that is my take on this question of yours. Thank you.
Excellent, sir. So, from your experience, sir, nowadays with better qualities, HR, CT scan, and those things, so do you think that it has made our job easier?
100%. It has made it much easier than the time when I was started practice, where the scans were of poorer quality or not there practically, and we didn't have much. But at least at a pulmonologist, we hardly do.
And also, one just an out of text question. Just nowadays, whether you are seeing the calcified lymph node number is decreasing, possibly because silicosis is nowadays is going out, as well as the tuberculosis persons are starting the anti-tuberculosis drug earlier. So, from your experience, are you seeing the number of calcified?
I completely agree with you. The patient, that one patient who have seen tuberculosis and all which are calcified, generally they are little elderly people. I mean, at least middle-aged and elderly who maybe had TB 20 years ago, 15 years ago. Not the youngsters. The younger people, they have taken the adequate treatment, and that includes MDR TB, impaired lymphadenopathy. MDR impaired lymphadenopathy just vanishes. You give the adequate one betaquilin based regime or whatever regime, and you will find that after 24 months or 18 months, whatever the period is, there are no nodes. They're just not calcified. There are no nodes. It's just gone. So that is, and even if there are some residual nodes are there, but not necessarily calcified. So that point of yours is well taken. I agree with you.
So Dr. Keyur has raised a very important also highlight I will show, and that he told that whether Kikuchi's disease is another important cause of necrotizing lymphadenopathy. I think we all will agree. But also, absolutely,
I have seen quite a few Kikuchis, and that is why you mentioned. That is what you mentioned. You have to get tissue. There is no way just on an image or CT, PET, whatever, you start treatment. I remember I had a patient of this necrotizing lymphadenopathy. The biopsy showed histoplasmosis. That lady was from your West Bengal. I don't know how she got it, but she and I remember treating her with amputation. She went back. So if I had not done that biopsy, I would have given her TB treatment unless. So you must never.
And also, sir, biopsy to be seen by an experienced pathologist. Just today, I'm telling you, one of my patient just had a mediastinal lymphadenopathy. He was guided, TBNA was done, a granuloma diagnosis was made, and we started the patient on ATD. So 4 months down the lane, again patient is symptomatic, not having significant improvement. Now with a little bit of pleural effusion, also pericardial effusion. And now he's having an enlargement. So we didn't think of histoplasmosis, just we had an enlargement of adrenal. Compared to the previous CT scan, this time we went for the adrenal biopsy with writing that we had a suspicion of histoplasmosis because of the adrenal enlargement. And you believe me, that biopsy slide, when reviewed by experienced pathologists, the previous one also, not only the newest one from the adrenal biopsy, now they are saying from that one also they are suspecting histoplasmosis. It is very important to have a history. It is also.
Is West Bengal
yes, sir.
histoplasmosis, because that girl of mine was from Kuch
Yes,
Bihar.
sir, from West Bengal, from West
So,
Bengal.
is that a histoplasmosis in West Bengal? Is it
No,
something?
I will not tell you that it's an histoplasma endemic zone, but there are frequent reports of histoplasmosis, also possibly because of the fact that we had one or two very good pathologists practicing in the city who have seen a lot of histoplasmosis cases. So ultimately, end of the day, it will depend upon the pathologist, sir. The urinary histoplasma antigen, you will also agree, will be positive only a few individuals. So it will only be diagnosed if the pathologist is aware of this, and also we as a clinician are suspecting that. So Kikuchi disease, Dr. Keud has absolutely rightly pointed out that Kikuchi disease is a very important cause of necrotizing lymphadenopathy, which we all should be aware of that. It will be like TB lymphoma, a presentation of generalized lymphadenopathy, exactly like that. So now I will go to the Dr. Nikhil again regarding the dense hilum, hilar overlay, and hilar convergence. These three signs, although I know you are handicapped because of you will not be able to show the pictures, but still a brief in which are conditions we will get it and what do we mean by those signs?
Thank you for this question, sir. First of all, the dense hilum sign, as we discussed in the starting, the dense hilum sign is a pathological process at the hilum. Here, in a well-centered chest X-ray, that is no rotation, and the density of hilum is comparable on both the sides, and there should be absence of calcification. The hilum should be of equal density and symmetric. If these things are not there, one hilum is denser as compared to the other side. This is the dense hilum sign. Then, when the hilum is dense, we would like to see if the mass or the opacity is due to hilar structures or it is anterior or posterior. So, considering this as a hilar mass, right? If we see vessels going through the mass, that is, we can appreciate the vessels going through the mass. So the mass is either anterior or posterior to the hilum. And then coming to the hilum convergence sign. So if the vessels are going into the mass like these, so the vessels are converging onto the mass. So the mass is of the vascular origin. If it is of any other origin, the vessels will be splayed by the mass. So these are.
No, I think it is brilliantly described by you without showing the picture. This is the best thing what you can describe. So now I will go straight away to again Dr. Tridib sir, to whether we should play any particular importance to this sign, or is there no importance of this sign? Just have a brief idea of how does a hilum look like, as well as Dr. Raghu, I will ask this same question. So because nowadays in the CT scans era, whether there is any particular importance of these signs to pulmonologists, I will go to you as well as Dr. Shweta as well as Dr. Sudhindra. So should we require to remember all those signs?
Let me be myself be very frank. I have not really because when the hilum is prominent and you think it's the thing there, generally we go for a scan. But as a radiologist,
Yes.
probably it will be good for. It's good to know about it. I mean, I don't think we should not know about it.
Yes, sir.
But
possibly these are all for the examiners and the examinees, when these kind of things will be shown to you and they will be asked to pronounce which are the signs, or nowadays even in the MCQs this may be asked. But I think in real life, in the era of CT scans, we do not place that much importance in real life to those signs. I think you will also agree, sir.
Definitely.
Okay. So now I will go to Dr. Raghu, sir. So what are the non-invasive tests you will recommend apart from the EVAS? It has,
You can close this now. You can close
so what are the non-tests? Is there any role of any non-invasive test? Because you will go for anyway the EVAS guided TBNA or conventional TBNA. So any non-invasive test will help you in diagnosis apart from the contrast and CT scan.
Definitely, sir. First we do routine investigation like CBP, etc., CBP, RFT, LFT, etc., and immunosuppression like HIV, sputum for CBNAT, sputum for malignant cells, and main thing is Montauk's test. And when you are seeing a case of lymphadenopathy, you must go for Montauk's test. In sarcoidosis, Montauk's test should be negative in 90% of cases, and mostly positive in tuberculosis cases. And in healthy also, negative may be present. But if there is a node enlargement, Montauk's negative, you must think not only sarcoidosis but also malignancies like lymphomas or bronchogenic carcinoma. Second most important thing we forget is ACE levels. Serum ACE levels are raised in sarcoidosis. Minimal rise may not be different of sarcoidosis, but high rise mostly in case of sarcoidosis. And increased levels may also be seen in other diseases like tuberculosis, histoplasmosis, coccidioid microcephaly. And then last is the CT scan. CT scan is not the plane with contrast change. So in the contrast, lymph node enhancement will present in different diseases like Castleman disease, a full enhancement will be present. And tuberculosis also less enhancement present. Lymphomas less enhancement will be present. And other investigations like ultrasound chest, mostly we use it for pleural effusions, but it may also be useful. And MRI scan, when there is a mediastinal fibrosis like that, you must go for MRI. That may be useful. So main thing in the diagnosis of hilar adenopathy is CT scan chest with contrast.
So, Dr. Tridib Chatterjee, sir, do you want to add anything to that? And then go to you regarding the straightforward question that what are the invasive tests? So,
what he has mentioned.
To add anything on to non-invasive or any particular 2-3 tests non-invasive which you specifically look for in case of high?
These non-invasive tests are very good. 1, 2, or a positive, negative, or a ACE level, as he has already mentioned. But I mean, this will just add more to the biopsy. I think finally you will have to get a more definitive diagnosis. But yes, because what happens, as I tell you now, typically this TB and sarcoid. Now these people, when you do a biopsy, they just pathologists typically will report as multiple non-caseating granulomas seen, A, B not seen. Please clinically differentiate between, you take a differential diagnosis which is this is TB or sarcoid. They will not, you cannot. And this has been going on for hundreds of years and will continue. So there's such situations, if, as he mentioned, there is a MANTU negative, there is an ACE level high, calcium levels are high, then this is an additional information which makes you start patient only on steroids. So, those are the things. Basically, these are important, very important, but they are not the only diagnostic test. Finally, as he mentioned, a contrast scan and then some sort of biopsy, either through EVAS or which I will be describing now, to get a confirmed diagnosis. That is what I think.
Sir, about non-invasive test, I will add up. Like we do CEA levels in patient of adenocarcinoma. And suppose a patient is suspecting, we are suspecting a cancer in a patient, and we are not getting, suppose the tissue is not sufficient. So we also do liquid NGS. Like suppose a person has been done biopsy once and he's not finding a block, or second time biopsy is not possible. Then we are doing tumor mutational burden and NGS from the blood, where we get EGFR L-cross without biopsy from the blood itself. And the tumor mutational burden also we get from blood.
That's a very nice.
Absolutely.
Very
Absolutely.
good information.
Very good input.
Yes.
And sir, even nowadays, any one of the, even Dr. Shweta may answer. So whether we should go for the TBNA, or nowadays we all are speaking about the cryobiopsy, because we all know in TBNA it is very difficult to go for the that much chunk of specimen to be subjected to the immunohistochemistry and to have a confirmatory diagnosis, what Dr. Satish will be asking. So whether it is possible to go for cryobiopsy, do you think in 5 years or 10 years down the lane, like nowadays, EBUS is replacing the TBNA, conventional TBNA. So do you see 5 years, 6 years or 10 years down the lane, EBUS guided cryobiopsy will be replacing the EBUS guided TBNA?
Yeah, so I can.
Sir,
Go ahead, Shweta, please.
No, sir, no, sir, you go. Sir, I'll say after you.
I had actually prepared this, so that's why I have some literature which I would like to share.
Yes,
so,
sir. Yes,
this EBUS, I mean, EBUS, everybody knows about EBUS. EBS TBNA has been the gold standard. But to improve on the EBUS TBNA, two procedures have been started. One is doing an EBUS cryobiopsy, and one is a mini forceps biopsy. These two things have been added, and they have, in certain trials, I've seen that it has increased the chances of diagnosis increased by almost 10%. In the cryobiopsy, they have, in the mini forceps, they, after puncturing it through the 19 number, through the same hole, they under the ultrasound guide, under the EBUS guidance, they put a special type of small forceps, which is similar to our regular bronchoscopy forceps, but it's a mini forceps. And under vision, they take pieces, and then they get better pieces. And they have found that without really compromising on the risk and the bleeding and etc., hardly 1% more chances. They have found that they have got much more tissue for immunohistochemistry and all mutation studies. Similarly, this electrocautery, which I think I read an article, it has been done in India, in Hyderabad. I think Dr. Harikrishnan has done some 5 cases. I saw an article by him in PubMed that they are using the cryobiopsy again the same way. Through that, they are putting in a cryo, and that's it is, I think, 1.1 size, and for three minutes they activate it, and they have got good results. There is a slightly increased chance of bleeding and pneumothorax, but otherwise, by and large, it is still used. But only thing is, whatever literature I saw, that it is unlike an EBUS where you might be able to, EBS TBNA, where you might be able to do 2-3 stations. Here, a cryobiopsy, as of now, has not been able to do 2 stations together. Some of these people are, before doing the cryo, they are also using an electrocautery to make an incision to put in the cryobiopsy. But these are very exciting times. And probably, as you rightly said, in the next 4 or 5 years, it might be a part of an EBUS. When you will do an EBS TBNA, yes, and then you will follow it up with a biopsy or a cryo or something to get better tissue. This is what the future looks like. That's what I would add. Shweta, you can add anything what you think is it.
No, sir, nothing more than that.
But
so just a final question.
No, one last thing is that
no, sir.
We must not forget a CT guided biopsy. It's much more cheaper. Certain times it becomes much easier to do. It is if there are paratracheal nodes or there are big enough hilar nodes, subcarinal nodes. I think Dr. Nikhil will enter. It's much cheaper, and for the patient, and we get almost the same amount of tissue as basically a TBNA gets.
Only thing is that you need to traverse a long path, no sir.
Yeah, so it all depends. It very much depends on the expertise. And one additional advantage of EBUS is that the picture, the appearance of the node on the sonography might give you some with a heterogeneous pattern, homogeneous pattern. Those things you cannot make out in a CT. But that EBUS does. But if it's a financial issue and the expertise is a very important thing. As you said, pathologist, here again the intervention radiologist, like I sent to Dr. Bhavi Jankare, who is one of the best. So so I know he's in safe hands. But yes, there is some chance of pneumothorax and all that, and they have to be prepared for it. So, but it is not to be thrown out. It is still there. It is still it's still done. That's what I think. Anybody wants to add, please go ahead. Dr. Satish, you do a lot of things. Would you like to add to this EBUS, CT guided, whatever comes to your mind? Please go ahead.
No, sir. Whenever we have a lesion in the chest and we don't have any accessible nodes, then we go for CT guided biopsy. But whenever we have a more accessible site, suppose a patient with CA lung comes with a node, then we will go for a nodal biopsy, because that gives us two things. Once it proves it's a malignant, the node which we are dealing with is a malignant, and proves that the upfront is a stage 4 disease, and that gives us a primary diagnosis as well.
So staging you can do. That is a very major advantage. That is, I think I forgot. Staging is somewhere where EBUS scores much more.
And it is an important part of management of any kind of cancer. So the last question to all of the panelists before wrapping up today's talk, it's almost 9:30. So what is the role of surgery or any role of thoracic surgery in any kind of highlight diseases for diagnosis as well as for any kind of treatment, any one of it? So role of surgery or thoracic surgeons for diagnosis predominantly.
See, during my time, there was this media stenoscopy was actually done. But now EBUS has kind of pushed it out. So I don't think media stenoscopy is done
only
anymore.
Sir, possibly in some cases of aortopulmonary lymph node or
where it is very difficult to get through EBUS.
Very difficult only still live.
Sometimes if you do not get anything, then you may be forced to do a VATS. I don't know. Theoretically, yes, VATS.
Yes.
You have to consider if you have tried EBUS, etc., and you're not got, then final, it's like when you don't get a cryobiopsy, you have to do a VATS biopsy for a diffuse lung disease. So same way here, if you do not get anything, then probably VATS has to be. You have to keep it in the armamentarium, I guess. Doctor, anybody wants to add to this? Please go ahead.
I will go to Dr. Satish also. From an oncologist point of view, do you recommend any patient to be done by thoracic surgeons?
So basically, most of the work is done by either intervention radiologist or by EBUS.
Intervention.
Till now, I have not recommended anybody for go.
Yes. Dr. Shweta, do you want to add anything?
So almost all the work is done by the intervention pulmonologist. But in certain cases, like if there are conglomerated lymph nodes like subcarinal or any other lymph nodes, hilar lymph nodes, which are putting in great amount of symptoms because of the pressure symptoms or mass effect, then in that cases, if it's a cold abscess or something like that, then we can refer to a surgeon. But most of the things are done by the intervention pulmonologist.
Maybe 1% of cases, maybe they are only.
Very few cases.
Yeah,
okay. So any other points by any one of the panelists you want to highlight, or any message do you want to give to the audiences, our wonderful audiences who have joined in such a large numbers before concluding the session?
But I just want to add, whenever you are suspecting, suppose we are doing a biopsy of hilar mass. If you are sending it for gene expert, do you regularly send it for cytology also to look for malignancies?
Yeah, I think nowadays it is. I think now really done, because most of the persons are nowadays aware. Tridib sir will be aware of the past.
If you have taken the trouble of doing a CT guided biopsy or an EBUS, it is your duty to send
in both the samples,
the entire microbiology, which may include a fungal culture also. Please note, I'm not just talking about MGIT culture and routine culture, because you're not going to do it again. You can't call the patient away, I've seen something fungus, we'll do EBUS again. It is at that one shot. You have that one shot. You have to do everything.
And so just adding a 5,000 rupees investigation to once you are doing an EBUS, that patient can afford an EBUS. So there is
no.
in just sending just for a cytology or just for a gene expert. Once you are doing EVAs, I absolutely agree with you. You cannot repeat those tests. You cannot repeat the fungal culture from a formalin sample. So you need to send once you are suspecting something. And it is also not the suspicion. You need to send it. Many a times you will get the report when you are not suspecting. It is not necessary that you will be suspecting something.
In fact, let me confess, my mistake with that patient I told you, because I had not sent fungal culture and I had made a mistake, and I'm confessing here on air. So I had sent, just because it looked like TB, I had just forgotten to send the fungal culture. A senior microbiologist told me that I can see histoplasma. Where is the culture sample? So I immediately quickly phoned Dr. Camellia. She says, sir, all the sample is gone for MGIT culture. I had a tough time. I convinced that patient. I convinced everybody and repeated the CT guided biopsy. Believe me, I could manage to do that after a lot of persuasion, and then I got the second biopsy. So after that, I remember, when you do everything. Never miss out anything. This is from experience. I'm telling you, never miss out anything. Even if it's an obvious malignancy, send it for gene expert, send it for routine culture, send it for fungal culture. It will not be a huge amount of money for. But you can't do the procedure again. That is absolutely not that.
So I think now I want to thank all panelists, starting from Dr. Sudhindra Raghu sir, Dr. Nikhil Gupta sir, Dr. Satish, Dr. Shweta, and at the last, I must thank for actually guiding us all, Tridib Chatterjee sir. So, and all the organizers of CCI for allowing me to moderate the session. And I think now it's time to wrap up the session. Thank you. Good night to everyone.
I must congratulate you for a very good moderation. So
no,
very
sir,
nice.
Thank you.
Thank you.
Very nice.
We really enjoyed. Thank you very much. Thank you, everybody. Good night.
Thank you. Good night. Good night.